to cover, I'm going to start off with the ligaments of the knee. We already kind of covered that last week. Remember what each ligament is going to do, right? So ACL, anterior cruciate ligament, does what? Anterior tibial or posterior femoral. Okay, those are both equally important to remember, because what's going to happen is you're going to have somebody, and I've had so many injuries like this. They jump or they get thrown if it's cheerleading, right? I'll tell you, I've seen tons of cheerleading injuries. They hit the ground like a cat on their feet. They hyperextend their knee. It goes pop. I get to see them for the next 16 weeks. Okay, so anterior tibial translation, posterior femoral translation. PCL, posterior tibial translation, anterior femoral translation. Okay, so you have to think about those things. So in reading a lot of these test questions, the mechanism of injury is going to start becoming very, very important. Okay, we kind of did a little bit of that last semester, if you guys remember those shoulder dislocations and all the different dislocation directions, is going to start becoming very, very important. LCL, or fibular collateral ligament, or lateral collateral ligament, does what? It checks lateral displacement, lateral gapping. Okay? What structure supports the fibular collateral ligament? IT band. Okay, is the IT band contractile tissue or non-contractile tissue? Non-contractile tissue. How does the IT band contract? By my Starbucks drink, the tensor fascia lata, right? Exactly. MCL, or tibial collateral ligament. Okay, what does it check? Checks genu valgus, checks medial gapping. It's supported by what? Pes Anserine or Pes Anserine. Means goose's foot. We're going to get into a little bit of that today. Pes Anserine is what? What type of structure? Contractile or non-contractile? The actual Pes Anserine. Non-contractile. Okay, now that's going to become a really, really big key detail, because in your treatment plans, whether you are treating contractile tissue or non-contractile tissue is going to change your plan. Okay, you guys are going to learn that a lot of tendinopathies really like eccentric contractions. Okay, so you guys will get into that over the summer a bunch, but that's why I want to really kind of drill home where these injuries happen, not only in anatomic location, but also what substance or what structure, what material is actually injured is going to become more and more important as you go. Okay, Pes Anserine is made up of three muscles. What are those three muscles? Gracilis, semitendinosus, and sartorius, right? Okay, that last one seemed to get to you. Okay, that's okay. All right, sartorius is innervated by what? Femoral nerve. L2, L3, right? Gracilis is innervated by what? Obturator nerve. Am I going to have to kick you out of class, Dr. Justice? Oh, jeez. And semitendinosus is innervated by what? Sciatic nerve? Okay. When you guys are studying, this is how I want you to study, right? So what did we just do there? Okay, let's take this structure, and then let's add on all these different layers to it. Okay, that way you fully understand the material. All right, any questions about ligaments of the knee? Yes.
So you said the PCL was post-tip translation. What was the other piece to it?
Figure it out, you tell me. You got it. All right, now you guys know well enough that we can't get through any part of the body without talking about our favorite subject in the world, which is blood supply. Thank you for rolling your eyes. I really appreciate that. That was fantastic. All right, so when it comes to blood supply, especially the arterial supply around the knee, here's the really, really good thing. All of these great little arteries that we're going to cover all kind of flow into the same network, okay? So do we have anyone from Pittsburgh here or familiar with Pittsburgh? All right, why do they call it Three Rivers? Because there's three rivers. Okay, which river flows into which river?
Allegheny created the Ohio.
Okay, there you go, right? But they just kind of all flow into this one big thing. So that's what we're going to see around the knee, is we're going to see all these different sources of blood flow from the posterior aspect and from the anterior aspect and from the lateral aspect and from the inferior aspect, all pushing blood into and around the knee. The good thing is that a lot of the little tiny branches don't have names in grades, okay? The actual names are going to be the communicating branches, but they don't have names in grays, and as you can see from the picture, I ripped that right out of grays. So the first thing we really need to cover here is going to be where a lot of this blood flow comes from. Now, as we've talked about in the past, we have this great femoral artery, right? This great big old femoral artery, and that's going to do its thing. Okay, so this guy here is going to be our femoral artery. Now, the femoral artery is going to pass through an anatomic landmark. It's going to pass through an opening. That opening is going to be the adductor hiatus. The adductor hiatus is going to be an opening or an aperture through the adductor magnus muscle. So this is my adductor hiatus. Before the femoral artery goes through that adductor hiatus, it's going to throw off a branch. And this branch is going to be called the descending geniculate artery. Okay, says what it is what it says. Okay, it is the genu or geni or genus, the knee artery that descends. Easy as that. Okay. Now, what I'll tell you is the difficult portion of vascular supply of the knee is the fact that we have to understand where all these arteries are coming off of. Okay, because we're going to see some arteries are going to come off the femoral, some arteries are going to come off the popliteal, which we're going to get into next, and some actually are going to come off of the branches off of the popliteal. Okay, and we're going to get into that in a little bit as well. So after my femoral artery goes through the adductor hiatus, it's going to now be called my popliteal artery. Now understand that this whole section is going to be posterior knee, because that's why my femoral artery has to go through that adductor hiatus. It's going to zip to the back of my knee. And in fact, that's exactly what popliteal means. It means back of knee. So this is my popliteal artery. Now here's the good news. The good news is that my major arteries that are going to supply my knee are going to come off of that popliteal artery. Okay, and I'm going to have 4 of them. They literally are all named based on their position relative to the knee. I can personally remember when I was in PT school freaking out about a lab exam. Trust me, I did it too. And I was sitting there trying to memorize all these little knee arteries. And one of the TAs came over and was like, why are you worried about this? Literally, look. Superior lateral geniculate. Superior medial geniculate. Just look where the knee is. The one that's superior medial is called superior medial. I didn't freak out nearly as much after that. Trust me, I was a PT student. I still freaked out. But it made it a lot easier. So a lot of times just understand where and why these arteries are named. So like I said, I'm going to have 4 arteries come off. These arteries are all going to wrap around. They're going to come from the back side, and they're going to wrap around to the front side. I understand this is a 2D picture and done by someone that draws like a kindergartner. What's that?
3rd grade, easy.
3rd grade, yeah, you're right. I need to give myself more credit. Yeah, third grade definitely. Not more than 3rd though. All right, so these are going to be my 4 big geniculates. I'm going to give you a couple reference points here. Over here is the lateral side, and over here is the medial side. And in fact, I'll do you one better. Let's draw in my tibia. Draw my fibula. Here's my fibula. There's my tibia. Okay, so I'm going to have 4 arteries coming off the popliteal artery. I'm going to have one called my inferior lateral geniculate. I'm going to have one called my superior lateral geniculate. This is how easy this is. I'm going to have one called my superior medial geniculate. And then, for bonus points, anyone want to guess what the other one's called? Just want to say carotid. No. Inferior medial geniculate. Okay, so that's going to be the big arteries that come off of the popliteal artery. Now, what you kind of have to imagine here, and the book does a much better representation, is what you have to think about is those arteries are branching directly off the popliteal, which is in the posterior compartment. They are then wrapping around to the anterior compartment, and they're going to feed into this communicating network of arteries in and around the knee. All right, any questions on that? So a couple more branches here. After the popliteal artery gives off those branches, it's then going to split into 2 more respective branches. A posterior tibial artery and and anterior tibial artery. Now, what we're going to learn coming up after the midterm is that up to this point, typically the artery and the nerve are basically named the same thing based on position. The lower leg is going to be a little different because what we're going to find is that the anterior tibial artery does not follow the anterior tibial nerve. It follows the deep fibular nerve. You're going, what? And it'll make more sense next week. But this anterior tibial artery is going to be the one for today that we're going to focus on, because it's going to continue on and it's going to pierce through something called an interosseous membrane. Okay, we already kind of encountered one of these last semester when we started talking about the difference between the radius and the ulna. There's an interosseous membrane between those two structures. The same thing is going to happen here. I'm sorry? Exactly, right? So my anterior tibial artery is going to shoot through an aperture, an opening in the interosseous membrane, and it literally is going to give all the blood supply to the anterior compartment. Okay, and we're going to get into this a little bit next week, in the next couple of weeks actually. And some of you may be familiar with this, the term anterior compartment syndrome. And we're going to get into how you diagnose anterior compartment syndrome, because it's nothing but a big pattern. My anterior tibial artery is going to give off a branch, and that branch is going to feed back towards the knee. And it's going to feed back in this big communicating system. And that's going to be called the recurrent geniculate. It also goes by tibial recurrent, anterior tibial recurrent, and there's about 18 other names it goes by. For testing purposes, make sure the word recurrent's in there, because that's about the only word that's consistent amongst the entire nomenclature, okay? So why do we have this system? We have this system, if you guys think about it, for a couple of really super key reasons. One is I need to get blood all the way around my knee, right? My menisci need blood, my ACL needs blood, my patella needs blood, my VMO needs blood, all this great stuff. I only have one source, and it's located in the back, right, the popliteal artery. So I need to wrap around and get all these extra arteries around so I can get blood supply. The anastomosis system is set up that I'm going to have a lot of lateral communicating branches between all those arteries, so that if one goes down, I can still get blood, albeit not great, but the tissue can still survive. Okay, any questions on blood flow? Yes?
So the recurrent geniculate, is that on the anterior side?
It's on the...
It's still everything on the posterior still?
No, so that's a good question. The recurrent genicular artery comes off the anterior tibial. Okay, what we're going to learn is that popliteal artery is going to come down. It's going to split in the posterior anterior tibial. That anterior tibial is going to shoot forward, and then the recurrent comes off the front. Yeah.
Thank you.
Yep. Like I said, the picture in grays does it a much more justice. All right. Any other questions about blood supply that they need? Everybody good? No, that's fine. That's fine. That was going to be my next question. Good? Okay. All right, so next point, and this is going to mimic tests and measures from last semester. I want you guys to review that material because sensory exam lower extremity can tell you a lot of stuff. In fact, I would argue a lot of the patients that you're going to see, I've been able to root out and diagnose a lot of low back issues through the sensory exam, through dermatomes, through myotomes. Understand how those dermatomes are made, right? So what's a dermatome? Right, area of skin, derma, right? Derma means skin, innervated by an efferent or afferent nerve. Afferent. And that's the greatest collection of afferent nerve fibers in that particular area. Okay, my recommendation is that you really review your lower extremity dermatomes, okay? All the way from low back, all the way down to this information we've covered so far. Okay, so the big ones you're gonna see in the thigh and the knee are number one, this L2, this guy here, and L3. Those are going to be the big ones you're going to see in the thigh and the knee region. Now, the reason that this can become so important is because if I have an afferent nerve injury, okay, I have some sensation problems. Here's what's going to happen. The diagnosis is going to be what? So you're going to get, what's the referral going to say? It's going to say leg pain. Or it's going to say sciatica. Now, what makes up the sciatic nerve? Tibial and confibular. What are the root levels? L4 to S3? Okay. So if I got L4 to S3, why in the world would I have dermatome issues, aka altered sensation, aka numbness or tingling at L2 and L3? Why would that happen? What's that? So I got someone who bid referred pain. Ooh, I can turn this into like Price is Right. This is great. Why? You guys are thinking way too hard on this one. Because the person that referred them, when someone has leg pain, they call it sciatica. That's it. Can you say one more time? Posterior leg pain can be sciatica. I had someone come in, honestly, in my career who had diagnosis from sciatica or diagnosis of sciatica. You know what they had? They had a hamstring pull. But, well, here's the thing. They went to their neurologist. Right? So neurologist is automatically going to be tipped a little bit to what? What sort of structures? My nerves, right? My brain and my spinal cord and my peripheral. Passive accessory motions. I cranked on them 6 ways from Sunday, and I could not reproduce their leg pain at all. Guess what reproduced their leg pain? Stretching out the hamstring. Yeah, or flexing the hamstring, contracting the hamstring. So I called the neurologist and I said, I saw, Mrs. McGillicuddy, and, I wasn't seeing any sciatica, but I do think she has a hamstring pull. Is it okay if I go ahead and, on the treatment plan, write down hamstring pull, and you go ahead and sign off on it? You know what the answer was? Yeah, sure, whatever. Yeah.
At least they recognize their own bias.
At least they recognize their own bias. Exactly. So, and I have had situations where I've called up and said, hey, it's this and not this, or I think it's this and not this. And the referring provider says, no, it's that. You will treat that. What do you do?
Can they enforce that though? Like,
Let me ask you, can they? I love it when a student says it depends. We say it depends all the time. So it depends, right? Okay, I don't want to turn this into a huge debate, but what happens if I do? Maybe. What happens if I don't? All right. Am I working within my scope of practice? Am I not working within my scope of practice? Maybe this is where a little bit of delicate documentation comes in. Hamstring stretch turns into nerve flossing. Right? Tell me the difference. There isn't one. Right? Because let's face it, all these diagnoses are going to boil down to a couple different things. Something needs stretched, something needs strengthened, something needs stabilized, something needs balanced. Right? In the offshoot that you get a vestibular patient, crank their head around 6 ways from Sunday until they, and then, they're better. I will say, if you guys get a vestibular, 2 trash cans in the exam room is recommended. Mm-hmm. Oh, I love vestibular. This thing is great. It's one of the rare times where a physical therapist can cure someone in one visit. But sometimes you have to, I'm not going to say massage or lie or anything like that. I'm not implicating that at all. But if your referring provider is that hard pressed that is the problem, then sometimes you have to work in those restrictions.
You can do accessory and ancillary work, correct?
Absolutely.
Be associated with.
Oh, absolutely. Right.
You're definitely treating their diagnosis, but you're doing ancillary work with that.
Well, if you're writing functional goals, right? Okay, so you guys are familiar with functional goals at this point, right? SMART goals. So what's the goal, right? Am I going to write a short-term or long-term goal that says cure sciatica? Why not?
Writing a diagnosis.
Yeah, exactly. I'm writing a diagnosis. I'm writing how I measure that, right? There's really, it doesn't hit all those SMART goal things. What's my goal going to be though? Right. Patient can sit in chair during occupational time with no greater than 3 out of 10 on the pain scale. It's measurable, it's functional, right? It hits all those boxes. So then, does it matter if it's sciatica or hamstring strain? Heck no, right? Because I'm still going to address those functional goals, okay? All right, so know your dermatomes, please, please, please. Also, the other thing really to note here, and I wanted to bring this up because it tripped some folks up last semester, is the difference between dermatomes and cutaneous nerves. Okay, remember that my dermatome pattern is not going to follow my cutaneous nerve pattern exactly. There's going to be some differences. So big ones right off the top of my head that we're going to see in the thigh and the knee is going to be this one here, this femoral nerve. Because if you think about it, you flip back to the previous slide, it kind of hits L2 and it kind of hits L3. That's pretty convenient because it comes from L2 and L3. The other big one that trips people up is this lateral cutaneous nerve of the thigh, because it kind of hits the anterior portion, but if you look at the posterior picture, it kind of wraps around all the way to that lateral side of the thigh. It says what it is what it says. So the reason I bring things like this up is a lot of times you're going to have to differentiate. Okay, so for example, patient comes in, they have a referral for hip bursitis. Okay? Where is the big bursa on the hip that's going to get inflamed? Right at the greater trochanter. What is the dermatome that innervates that section of the hip? Is it L5? Then L5 get a little stream down there to the lateral hip. What? Let's get what? So yeah, L5 gives a little stream, but we're also going to get lateral cutaneous nerve of the thigh. We're also going to get all this other stuff. Now, what I want you to think about is how would you differentiate? Is it hip bursitis or is it coming from the low back? Let's take away the L5 for right now. Let's just say low back for right now. Okay, so how do I differentiate? Is it coming from the low back or is it coming from this hip bursitis or bursa? What would you guys do? What's that? Trunk flexion. Okay. Is that all?
No.
So your exam's going to be okay. Well, nothing wrong with you. Palpation. Palpation of what? Okay. So I could definitely palpate the trochanteric bursa, right? Because if I push on the bursa and it's bursitis, what should happen? It should go out, right? What do we call that? Isn't that a provocation test? A pain provocation test? You guys go over that yet in MSK1? No? Kind of sort of. I'm getting this and I'm getting this.
We didn't necessarily talk about, we just learned about provoking pain.
Okay, so we're going to go with provoking pain. Okay, next year you guys will get into what's a provocation test and all that stuff. All right, so I'm going to provoke pain. And that's really all I'm doing, even with the trunk flexion, right? So I'm going to move their low back around because what type of back pain do we treat in very broad terms? Mechanical low back pain. Right, so it has the word in it. So what does the word mechanical really mean? Based on movement, right? What's a machine do? As a bunch of moving parts. So if I can't reproduce their pain within mechanical means, they probably do not have mechanical pain, right? So understanding where these femoral cutaneous nerves are and other cutaneous nerves and your dermatomes is really key because you're going to have to differentiate whether or not that's a bursitis patient or whether or not that's a low back patient. That changes your treatment plan a little bit, doesn't it? Heck yeah, it does. All right. So finally, after no further ado, we're going to cover posterior musculature first, and then we'll cover anterior musculature, okay? So on the posterior side, I'm going to have 3 big old muscles that are going to perform the vast majority of my knee flexion, okay? As a group, these are called the hamstrings. Hamstrings is a layman's term. Okay, as a group, my hamstrings are going to do 2 things. Hip extension, knee flexion. Okay, nice and easy. So already, what you should start to think about is when in life, where do I perform hip extension or knee flexion? Where do I perform them against gravity? Okay, because that's going to be the other part of it. Remember, the big difference between last semester and this semester is the concept of weight bearing. So think about biomechanics, okay? Think about the difference between a concentric contraction, an isometric contraction, and an eccentric contraction. So before we go any further, if my patient is transferring from stand to sit, What is contracting? Who's going hamstrings? Who's going quadriceps? Why don't you guys all stand up and do it? Stand to sit. Stand to sit.
Well, if you sit, you shift weight forward on the knee and weight over your toes. You sit it back,
No ifs.
but it's not.
No ifs. We'll get into ifs later. Actually, the lab all gets into the ifs. Yeah. Right now we're face value. We are face value. All right. So what do we think? Okay, we're going from stand to sit. Are my hamstrings driving that motion? What's driving that motion? Gravity's driving that motion. Right? Okay, what direction does gravity go? Down. Okay? So if I am performing, even though the hamstrings do hip extension and knee flexion, I'm descending. Gravity's going with me. How do I slow that down? My quadriceps, right? Because my quadriceps are going to extend my knee, but they're also going to slow knee flexion. Because who's worked in the clinic before? Miss McGillicuddy's in your clinic, and Miss McGillicuddy's tired. How does she get into that chair? With authority, right? I mean, there's a little boom boom going on there, right? Tell me you guys haven't seen that, right? Go visit grandma or grandpa and go walk around somewhere for about 7-8 miles and ask them to sit down, right? They're gonna sit with authority. Why do they sit with authority? AKA, why do they plop? Because their quads are so tired that they cannot perform the eccentric contraction. Who here has seen a total knee patient who complains that I can go up the stairs no problem, but down the stairs is a whole nother world? Why is that? Because if I'm descending the stairs, what motion is happening at my knee? Knee flexion, right? I'm descending the stairs, knee flexion is happening at my knee. Gravity is driving that, right? What's slowing it? My quads. It actually takes more force to eccentrically contract than it does to concentrically contract, right? If you want proof of that, we can start doing pistol squats out front, and we'll see who gives out. Gary's already tapped out. It's like, no, I'm good.
Dr. Cox,
Yeah.
is that why I think Dr. Cox mentioned how we want to train the muscles eccentrically?
So good point. So Dr. Fox currently mentioned training muscles eccentrically. I would broaden that statement. You train muscles functionally. Okay, so what does that mean if I'm going to train a muscle functionally? Train it how you use it, exactly. Not only how you use it, but in the environment to a point at which you can use it, right? This is why when my linemen come into my clinic, bring your gaffs with you. You guys know what gaffs are? Leg irons, right? Leg irons with spikes. Has everyone ever put those on? They are heavy. Okay? Why do they have spikes? Because that's what they dig into climbing the pole. Okay? If you wear steel toes, you're going to wear steel toes in here. Who's worn steel toe boots before? Are they heavy? Yeah, they're heavy. So if I have an ankle sprain, or I have a knee problem, or ACL tear, or whatever, and I got to go back and I have to wear steel toe boots, aka EMS service. Do you wear steel toes for EMS?
Yeah, I usually just wear composite, by the way.
But good point. Composite toe because it's lighter weight. But bring in the shoes that you're going to wear on the job, right? Bring in the uniform that you're going to wear on the job. My police officers, they bring their belts in. Who's put a gun belt on before? They're heavy, right? Bring your flak jacket. You're going to train in your flak jacket because it's heavy. So train the muscle functionally. All right, so my hamstrings, hip extension, knee flexion. They are going to arise from various areas off of the ischial tuberosity. Okay, so we're going to draw in this little thing here. This is my ischial tuberosity. Down here, we're going to draw in, again, there's my tibia. And there's my fibula. So biceps femoris is going to be this large muscle that comes off of, according to Grays, the inferior medial aspect of the ischial tuberosity, right? And it has two heads. It's got this long head, and it's also going to have this short head that comes off the lateral lip of the linea aspera. It's going to attach in onto the head of the fibula. And that's going to be really important to remember because excuse me, let me erase that real fast. Here's what you have to think about. We already talked about the fibula being a non-weight bearing bone. Okay? We're cool with that. If my patient has a fibular head fracture, is it possible that they're also going to have biceps femoris problems as well? Yes, it is. Is it possible that if someone takes off during some sort of athletic contest and they feel a pop in the lateral aspect of their posterior knee, that biceps femoris is the issue? Could be. Present company excluded. The other two big hamstring muscles that we're going to have here, one's going to come off of ischial tuberosity, and that's going to go down to the proximal tibia. And it's going to come out to this really large membrane, and that should be a huge key. This is going to be semi-membranosus. Says what it is what it says. Semi meaning part, right? So when always has their semi-annual sale, that means it's part of the year. Semi-membrane. So that's why it's called semi-membranosus, because the distal aspect flattens out and fans out to a membrane. Semi-membranosus is paired with another hamstring muscle that's going to come off this ischial tuberosity, and it's going to come down, attach a little bit onto the proximal tibia, but it's also going to come down and be part of this Pes Anserine stuff that we've talked about. And it comes down to a very small tendon. It's called semi-tendinosus. Now, the other point that I want to make about the hamstrings, and this is going to get into a little bit of biomechanics here. Well, I'll cover this real fast and then we'll take a little break, I promise. Again, look what we have here. I have multiple muscles attaching to different spots that when they work together, they perform one motion. Okay? And the reason is because I have vectors. Again, you're not ever going to get away from vectors in the human body. I have a vector that's headed this direction. I have a vector that's headed that direction. Now, why is this important? It's important because you as a physical therapist are going to have to observe motion. That does not only mean observing large global motions like gait. It also means observing joint excursion. So if I ask my patient to flex their knee in a prone position, and I watch the tibia rotate one direction or the other, what does that mean? Right, one side's not doing its job. If I ask my patient to flex the tibia, flex the knee in a prone position, I don't see any rotation. That means that both sides of the hamstring, biceps femoris on one side, semimembranosus, semitendinosus on the other side, are all doing its job. Okay, so the quality of a lot of these motions is just as important as the amount they move, right? Just taking a goniometric measurement and going, well, they got to 140, that's not good enough. Okay, I need to see quality of motion. All right, let's go ahead and take 5 minutes, get up, prevent blood clots a little bit.
Sure.
Would you have like a Q in it or something? I'm kidding. I'm kidding. I'm kidding. Yeah. That's long. So it's just like biceps gripping, right? Same concept by
Gripping.
Ready
Ready to go. What are you trying to remember my first day, so it's pretty serious.
It's like, no, it wasn't that at all. It was, hey, you have to at least teach me better than all of us. You didn't have to. Or they asked. I shouldn't say they told me, they asked. I'm like, sure, I'll take that. That sounds like fun. Here. I don't know how to teach it out. I sat down and went, oh. I gotta teach it out. I actually reached out to my anatomy instructor, like, what do I do? Right, so what is it? Very thin, broad, flat, almost transparent structure. Yeah. So yeah, I'm just giving you the context why they're called. I understand that we get down to hamstrings, most of you guys, because of your undergraduate background, already like, oh yeah, femoral nerve got it, like it's not that big of a deal. But I still go over, remember I teach that, like you never had an accident. I think so think about it. Okay, when you believe it or not, unfortunately, we're going to get into that bus popliteus, and then how that relates to you can see the layers. All right. All right, so any questions on my knee flexors? There's going to be one other posterior muscle that we have not drawn in. I'm going to draw that in later when it gets into musculature control of screw home mechanism, right? So there's actually going to be more to this. So hamstrings, that's the layman's term. My hamstrings are semimembranosus, semitendinosus, biceps femoris, short head and long head. Biceps femoris named based on the fact it has two heads and it's in the femoral region. That's it. It says what it is what it says. Same concept that we saw with biceps brachii last semester, right? So what we saw with biceps brachii, two different origination, same insertion, right? So we saw that with biceps brachii, with biceps femoris. Long head comes off the ischial tuberosity. Short head comes off the lateral aspect of the linea aspera. They join forces, and they attach into the head of the fibula. All right, any questions on hamstrings?
So is Pes Anserine considered like the hamstring muscles or just like the area?
So what's Pes Anserine? You don't know? We covered it earlier in class. So remember gracilis, sartorius, right? So it's not just my hamstrings, right? So Pes Anserine, the reason it's important is because it supports my MCL, and it is one of the connections between my anterior compartment, my medial compartment, and my posterior compartment. Okay, so my sartorius is from the anterior compartment, my gracilis is from the medial compartment, my semitendinosus is from the posterior compartment. All three with different innervations, all three with different originations and actions, but all three come together for one cause. Okay, and it just looks cool. And, you know, anatomy cool. All right. All right, so that's my back side. That's my posterior side. The front side's pretty darn easy. All right, so on my front side, the big heavy hitter here is going to be my quadriceps. Now, quadriceps equals 4 heads, right? Quad means 4, ceps means head. I have 4 different muscles here. Rectus femoris, which we kind of covered already with the hip section. And then we're going to have the 3 vastus muscles. Vastus lateralis, vastus medialis, and vastus intermedius. Now, what we're going to see with these 4 quadriceps muscles is they have 4 wildly different originations, right? So same concept that we saw with biceps brachii, same concept we saw with biceps femoris, different origins, same insertion. So my rectus femoris, if you guys remember, is going to originate off of the AIIS, right? AIIS is going to stand for anterior inferior iliac spine. Please do not get those confused with anterior superior iliac spine. Okay? Please understand also which muscles originate at the ASIS. Rectus femoris is not one of them. Because I tell you, for testing purposes, expect to see something that says, hey, your patient had an avulsion fracture at the ASIS. Which of the following muscles would be involved? And I guarantee you rectus femoris is going to be in that distractor list. Okay? And I'm not telling you what's on the test, because I honestly don't remember what I put on the test. But you could probably see that as being a potential test question. Vastus lateralis is going to have all sorts of origins, right? It's going to come off of just about everything and anything this side of the femur, right? It comes off the intertrochanteric line, it comes off the greater trochanter, it comes off the gluteal tuberosity, it comes off the lateral linea aspera, blah, 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 right? So basically, everything that's over here, it comes off of, okay? Vastus medialis, same thing, right? Upper 2/3 of the anterior and lateral femur, all that great stuff. Big thing to remember here is that all these 4 muscles and vastus intermedius is the same thing, right? So vastus intermedius, I'm sorry, is the one that comes off the upper 2/3 of the inferior and lateral femur. Vastus lateralis, where it kind of went over. Vastus medialis, medial intertrochanteric line, pectineal line, medial linea aspera, medial supracondylar line, basically everything on the inside. These are all going to join forces and all dive into something called the patellar tendon. The patellar tendon, and you guys have probably already seen this cadaver lab, very thick, very robust, very, very structurally sound, right? It's a big old tendon. My patellar tendon is going to completely envelop, it's going to completely encase that sesamoid bone called the patella. Cool. One thing to note, and this gets into a little bit of semantics here, okay? Tendons are what type of structure? They attach what to what? Muscle to bone. Ligaments are what type of structure? They attach what to what? Bone to bone. Okay, is everyone good with words on the page here? Okay. This is a little bit of a, I'm not going to say detail, this is a detail. And you will get this in the clinic a lot. Especially when it comes to like ACL grafts and things. All right. So here's my patella. This whole group of purple lines here is the patellar tendon. This whole group of little green lines is the patellar ligament. Even though it is the same exact structure, right? So patellar tendon is obviously the conglomeration or confluence of the 4 quadriceps muscles. It envelops the patella and then rides on down to the tibial tuberosity. Once the patellar tendon gets into the patella, I am now not attaching muscle to bone anymore. I'm attaching bone to bone. So one thing to watch out for, especially for things like lab exams, is where the needle or where the flag is placed relative to the patella. So if the flag is placed superior to the patella, that would be called the patella or patellar tendon. If it is placed inferior to the patella, that would be the patellar ligament. Okay? So that's one key piece of information that you're going to need to know, because, like I said, technically, to keep consistent with anatomical terms, tendons attach muscle to bone. Ligaments attach bone to bone. What? Yes.
Oh, patellar tendon is the same thing, quadriceps tendon, right?
Yeah, that's correct. Yep. Yeah. So patellar tendon also goes by the name quadriceps tendon. Yep, those are synonymous. Okay, so patellar tendon, muscle to bone, patellar ligament, bone to bone. Patellar tendon, superior to the patella, patellar ligament, inferior to the patella. The reason I'm belaboring it this much and repeating it this much is because it gets somebody every year. And I'd like this to be the year that it doesn't get anybody. Okay? All right. Any questions on that concept? Okay. Everyone good with this picture? Wasn't much of a picture. All right, so let's go over the quadriceps. All right, so what are the actions of the quadriceps? Knee extension, right? That's the big one. But one of my quadriceps does what? Right. RF, rectus femoris, also does hip flexion, right? If my quadriceps perform knee extension, what motion do they eccentrically control? Knee flexion. Okay? So we just kind of did that with the stand to sit example. So if my patient is transferring from stand to sit, what muscle is eccentrically controlling that motion? Quadriceps, right? Gravity is the force driving the motion. Quadriceps are slowing the motion. So if my patient demonstrates a stand to sit transfer that is at the same velocity or acceleration as the force of gravity, 9.8 meters per second squared, aka they sat with authority, what muscle would be weak? Quadriceps. Okay? Now, in lab, we're going to get into 18 gazillion variations of that, because what we're also going to learn is where you place your load is going to change that equation. Okay, and you guys that are familiar with some weightlifting and biomechanics and ergonomics work, know that a front squat is a whole heck of a lot different than a back squat. Whole heck of a lot different than a deadlift, right? Because the load is placed in different places. That's something to really consider when you're training your patients, right? When you're exercising and rehabbing your patients. All right. Any questions on that? No, quadriceps are pretty easy. They're a pretty big dumb muscle. You'll learn to love them though. All right, so next concept. Patellar movement. Now, you will have patients that come in, and you have some of you in this class may have already experienced this. You're going to get on a referral, and it's going to say Patellar Tracking. And the patient's going to say, I play football. I don't track anything. So what is patellar tracking? It's painful. That would be a symptom, right? Goes too far over. What does goes too far over mean? Too far over, like over its bank account, like it's overdrafting? Outside of the group. Okay. So my patella needs to sit where on the femur? In what groove? The patellar groove. Come on, you have to think the original anatomist for that one is like pretty easy. So what I have here is I'm going to have a patella. And I'm going to have a femur. And I'm going to have this little area in the middle. That's called the patellar groove. And here's what I want you to think about. I want you to think about how that patella stays in the groove. Me personally, I'm voting for magic. I think it's magic. Right? Little Harry Potter, little wand. I'm going to get to the point eventually in my career where they don't tell us. Exactly. Yeah, Trachypatellar. Yes, there we go. Yes. But what I want you to think about is how that patella stays in the groove. So what do you guys think? How would my patella stay in the patellar groove? Okay, we got tendon. What tendon? Patellar tendon. Okay. What else? Patellar ligament. Okay. What else? Fascia. What else? And this guy, not so much. What's that? You say just kidding? Your skin? Okay. I'll go for, you know what? Actually, that's not a bad point, because what do all total knee patients have? They do.
No, they're open.
Don't they have a big incision on their skin? Yeah, they have a big old incision on their skin. So would the big old incision on the skin potentially change the patellar tracking? Maybe, maybe not. Would all the staples that they have, or glue, or butterfly strips, or whatever else, or zippers, or whatever else they use that day? So I got some folks where they just need a zipper. They've had a few done. Would that change patellar tracking? Potentially. One thing that you guys have to think about, especially with the total knee patients, and let me ask you guys this. How is the patella handled and the patellar ligament and the patellar tendon handled during a total knee? Pushed out of the way, right? So they don't cut it. Okay, what they do is they pull it over, take something that looks like a big old tuning fork, and they move it out of the way. Because when they do a knee replacement, what components are they replacing? You're going to replace all articulating surfaces that need it, right? So that could be the distal femur, that could be the proximal tibia, that could be the patella, and sometimes they'll do an entire patellar replacement, or sometimes they'll do what's called a resurfacing. You guys know what a resurfacing is? Who's had a crown put on their tooth? Or who's had a bridge? They buzz it down, grind it down, and they stick either a piece of plastic or metal on the back of it. It's called a button. So one thing to understand, and this is where you have to do a little bit of digging, all total knees are not made the same. Okay, here's the other thing you guys have to think about. What other structures have to be removed in order for a total knee to be done? Which ligaments? ACL and PCL. They're gone. Never thought about that one, did you? Yeah. So here's what they do. Okay, so now, got a piece of metal on my femur, got a piece of metal on my tibia. Do I want those pieces of metal grinding against each other? Heck no. What's going to happen if they're grinding against each other? Not going to hurt. All the nerve endings are gone. It's going to shave off the metal. Where's that metal going to go? In the bloodstream. Do I want metal in my bloodstream? Not particularly. So what they do is they put in a spacer. Okay, it's a piece of polyethylene. It's like a plasticky material. That spacer has a post on it. That post serves as both the ACL and the PCL. So during the first year of my career, when I wanted to practice my anterior drawer tests, I took my total knee patients and I practiced because they all got a positive one. There's no ACL, right? I asked first. But what I want you to think about is I want you to think about what is going to enhance or what's going to help, or more importantly, what's going to affect patellar tracking. So we mentioned quadriceps, right? Quadriceps is a big one. We're also going to have two not so large but super duper important bands coming off the patella. And these bands are called the retinaculum. Okay, so we're going to have a medial retinaculum, and we're going to have then a lateral retinaculum. If you're going to sneeze, just sneeze. Yeah, I'm not sure what that was. So one thing that may happen, and one thing that you may need to check, and also one thing that I've seen happen with patients is that they will have what's called a lateral release surgery. When a lateral release surgery is done, typically it's done when the patella is pathologically medially tracking. Okay, so what does that mean? That means my patella is not sitting in the patellar groove. It's riding and it's tracking medial. Now, bonus question. Would that happen in a genu valgus or genu varus patient? Who's going valgus? Who's going varus? Who's going neither? Who's going? We have a biomechanics test tomorrow, so I don't know. Let's think about it. Okay? If I'm in valgus, I have squinting patellas, right? Would it not lend then to my patellas coming inward, aka medial? It could. Varus, it could, right? Because now my quads are contracting a little on the more medial side, a little more medial vector. The answer is, it depends. It really does depend on the patient. So, big point is, don't necessarily look at the diagnosis or look at the observation. Look at what your patient's doing. So with a lateral release, what they are doing is they are cutting the lateral retinaculum. That is extremely important because my patient then will not have that extra little piece of stability. So then all these other elements that promote patellar tracking are going to have to be strengthened even more so. And then what we'll get into later on, because obviously we haven't even talked about the tibial component of this yet, is how foot position and ankle position will help or hurt knee position. Okay, we'll get into a little bit of that later on. All right, let's go ahead and cut it there. See you guys on Wednesday.
Lateral release is done because of medial tracking?
No, lateral release is done because of lateral tracking. Did I say it?
For some reason when it said
Oh, yeah.